So now we'll start with RBC. So under RBCs, we'll be starting with the introduction to hematology as such. Then we'll see about the erythroid series, then the various types of anemia. Then we'll see about the aplastic anemia and bone marrow failure syndromes. Then the various shapes of RBCs. Then finally, we'll see about certain MCQ related questions, especially the vacuotenors and blood banking and transfusion reactions. So starting with the introduction to hematology, this hematopoiesis. What does hematopoiesis mean? Hemato means blood, while poiesis means to form. So formation of blood cells are going to be called as hematopoiesis. So this hematopoiesis is going to start at day 19, that is to say 3 weeks. Okay, so 3 weeks of the intrauterine life itself. Okay, so day 19 of intrauterine life, the hematopoiesis is going to start. So the first cell to form here would be the RBCs. So the hematopoiesis start with the production of RBCs. So so day 19 it is starting, right? So initially the hematopoiesis is going to take place at the yolk sac. So between 3 weeks to 3 months it is going to take place in the yolk sac. Then it comes into the liver. So liver is actually overlapping. So liver synthesis is going to start at 1 month itself. So 1 month till birth there is going to be liver, spleen and lymph nodes which are going to produce hematopoiesis. Then at birth, if you see, it becomes only the bone marrow. So only the bone marrow of all the bones is going to be producing the blood cells. But at puberty, so once they hit puberty, the bone marrow of only the long bones will be producing hematopoiesis. So what happens under hematopoiesis is the hematopoietic stem cell is the very starting cell. So this hematopoietic stem cell is going to be positive for CD34. So we had seen this already, right? So after this hematopoietic stem cell is going to form myeloid progenitor cells and lymphoid progenitor cells. So under myeloid progenitor cells, we have two colony forming units, which is GM-CFU and then EM-CFU. CFU stands for colony forming unit. So GM is for granulocyte and then monocyte, while EM is for erythrocyte and megakaryocytic. So RBCs, WBCs and megakaryocytes are going to be formed under the myeloid progenitor cells except lymphocytes. So the lymphocytes alone are going to be formed by the lymphoid progenitor cells. So lymphoid progenitor cells are going to give rise to B cells, T cells and NK cells. So under this GM-CFU, it is going to further subdivide into granulocyte colony forming unit and monocyte colony forming unit. So this granulocyte colony forming unit is going to give rise to the neutrophils, eosinophils and basophils, which are the granulocytes of the WBCs. So for this to happen, it is the GM-CSF. So GM-CSF is a colony stimulating factor for this granulocytes and monocytes. So GM-CSF along with that granulocyte colony stimulating factor is going to induce the GM-CFU to form this neutrophils, eosinophils and basophils. While from the monocyte colony forming unit, you are going to derive the monocytes. So for this, it is the GM-CSF again. So the granulocyte monocyte colony stimulating factor is going to induce the formation of this monocytes from this monocyte colony forming unit. Okay. So under this erythroid and megakaryocytic colony forming unit, this is again going to form an erythroid colony forming unit and a megakaryocytic colony forming unit. So from this erythroid colony forming unit, it is going to form the erythroid series of cells. So that is the RBCs basically. And this megakaryocytic colony forming unit is going to form the megakaryocytic cells, the platelet forms basically. So this is going to happen under the influence of erythropoietin for erythroid cells and then interleukin 11 for megakaryocytes, right? So this is how the hematopoietic stem cells finally form the blood cells. So for any hematological disorder, be it a neoplastic or non-neoplastic, you will have to examine the bone marrow and the peripheral blood. So that bone marrow is the site of production of these hematopoietic stem cells, right? Hematopoietic cells, right? So any problem in the bone marrow is going to reflect in the peripheral blood. So for bone marrow examination, we can do two things. One is a bone marrow aspiration, another is a bone marrow biopsy. Okay. So this bone marrow aspiration is going to be done using the Sala needle and the Klima needle. So both these needles are used for bone marrow aspirate. While for bone marrow biopsy, you are going to use the Jamshidi needle or a Triffon biopsy needle. So with the help of these needles, we have taken the aspirate or the biopsy now. So where do you take this biopsy or the aspirate? So the site in which we do commonly is the posterior superior iliac spine. So behind the posterior superior iliac spine is going to be the most prominent site wherein you can easily access the bone marrow. So PSIS is the most common site. Suppose the individual is quite obese, in that case the PSIS will not be visible clearly, and PSIS also gives the maximum yield of the bone marrow, so that is why it is the ideal site. But then in obese individuals, you can go in for a anterior superior iliac spine. So anterior superior iliac spine is the next prominent landmark, but in ASIS we don't normally do it because the femoral arteries are going to be very much near, so the big blood vessels are there. So in order to prevent damage to the femoral artery and bleeding, so we are going to normally prefer the PSIS, but in obese individuals you can go for the anterior superior iliac spine as well. But in children, you don't go in for this iliac spines, you just go for the upper part of the anterior tibia. So the shin basically, so in upper part of the shin, you are going, the bone is quite prominent, right? So in the children, you can take the biopsy from there itself. So after taking the biopsy, you will have to stain the aspirate or the peripheral smear or the biopsy, right? So for biopsy, you are going to stain it with the normal HE stain. For aspirate and peripheral smear, you can use various stains. So for starting with the Romanowski stains, which are the most common stains. So under Romanowski stains, we have multiple stains. So we have Wright stain, we have Jenner stain, we have Giemsa stain, and then we have Leishman stain. So these are all examples of Romanowski stain. So under this, the Giemsa stain is the most common stain which is being used. But in Leishman stain, it is going to give much more clearer nuclear details. So the cellular details are going to be much more clear with Leishman stain. So in bone marrow biopsy or bone marrow aspirate, Leishman stain is quite preferred. And also fixation is going to be the simultaneous step in the Leishman stain, because the stain itself is going to contain the methanol fixator. So for Leishman stain, the stain itself is containing methanol, so you don't have to separately fix the smear and then do the staining. So Leishman stain is kind of better also. And then we have other stains as well, like methyl violet, crystal violet. So these are going to be used under certain special scenarios. So methyl violet and crystal violet is going to be used to highlight the Heinz bodies. So Heinz bodies are going to be seen in G6PD deficiency. So G6PD deficiency is going to lead to G6PD deficiency anemia. So in there you are going to see this Heinz body, and this Heinz body can be usually highlighted by any supravital stain, but more specifically methyl violet and crystal violet. So supravital stains are nothing but supravital, meaning they are above something. So they are going to stain the cells under the live condition. So normally for any peripheral smear or bone marrow, you are going to actually fix the tissue, meaning fix the smear as in the cells will it is going to die after that. So nothing, it is just going to preserve the cell in its state of death. But then supravital stain, you can stain the live cells as such. So the cells are not going to be fixed here. So directly you are going to stain the cells, so they can be, you can monitor the actual production of the certain cells. So supravital stains we routinely use to stain for the reticulocytes. So reticulocytes, you can stain with the supravital stain. So because reticulocytes are normally seen in peripheral smear also, but it will look as polychromatophores. So in order to identify and give the perfect reticulocyte count, you will have to stain it with the supravital stain. Especially we have supravital stains like new methylene blue and then brilliant cressyl blue. Out of this, the new methylene blue is going to be the best stain for reticulocyte. And then we have toluidine blue stain. So tol blue stain, we use it for staining mast cells and basophils. So it is going to be a metachromatic stain. Metachromatic in the sense the stain color is going to be blue, but it is going to impart a different color to the cells it is staining. So basophils and mast cells are going to appear magenta colored here basically. So even though the stain is going to be blue, it is going to give a different color. So it is called as metachromatic stain. So example of a metachromatic stain is tol blue. So the tol blue is going to stain specifically the mast cells and basophils. So coming to the cellularity of the bone marrow. So whenever you are getting a bone marrow aspirate or biopsy, you will have to assess the cellularity. So the cellularity of the bone marrow, we have to calculate with the formula of 100 minus age. So 100 minus age gives the actual cellularity of the bone marrow. and with that you can compare whether the cellularity is adequate for the age or not. So in a child, if you see, the age is going to be less, right? So suppose it is a 8-year-old kid, so it is 100 minus 8 will be 92%. So 92% of it should be cells, and only 8% can be the fat, bone marrow fat. Okay. Suppose if it's an elderly male, like of an 80-year age group, so 100 minus 80 will be 20. So only 20% of the bone marrow is going to be cells, while 80% of it is going to be fat. So as the age increases, the fat is going to increase and the cells are going to decrease. So this is the thing. So normal cellularity, if you see, cell is to fat ratio, in an adult it is 50 is to 50 ratio. So middle age it is 50 is to 50, while in a child it is going to be much more cellular. So 75% cellularity and a 25% fat, while in old age it is going to be 25% cellularity and 75% of fat. So any mismatch in this, suppose when will you call it as a bone marrow is hypercellular or a hypocellular bone marrow? Only when it is not appropriate for the age. So based on that, we can come to a certain conclusion as to these things are the differential diagnosis for this kind of a bone marrow. So the normal ME ratio is myeloid to erythroid ratio. So normally myeloid cells are going to be much more higher than the erythroid cells. So the normal ratio is 3:1 or 4:1. While the fat is to erythroid ratio. So remember, read the question carefully. ME ratio is 3:1, while fat is to erythroid ratio will be 4:1. Right?